Thank you very much, Chairpersons. It's nice to see a lot of you here at this time of the day. I've been asked to you talk on the influence of neonatologists perform echocardiography in the clinical management of the critically ill newborns. I'm a recipient of the grant, and that's the only disclosure apart from anything else. That's the place where I work currently on my sabbatical. It's in Doha. Now, before I start, can I just ask you, how many of you believe that neonatologists perform echocardiography has a role in the clinical management? In favor of it, can I have a show of hands? Oh, wow, so it's all convert group. Excellent. Now, that makes it easy, but equally difficult. Now, this is a survey that was about 5 years ago that was published, and this was about 216 questionnaires. They were received from about 38 countries. And the simple question was asked: a baby is born at 25 weeks of gestation, at 6 hours of age, the mean blood pressure is 23 millimeters of mercury, baby is stable on mechanical ventilation, and a mean air pressure of 9 centimeters of water. So how are you going to evaluate this child for hypotension? And I think that's no surprise here, because if you look at the respondents, the majority of them, they were showing the the capillary fill time, the urine output, heart rate, and the color of the peripheries, and blah, blah, blah. But because we are talking on the functional echo side of things, so 75% of the respondents, they did say that they used echo, and they were primarily looking at the cardiac outputs, the fractional shortening, SVC flows. So there was a place that was identified that the functional echocardiography, people have some interest, and they are looking into babies when they consider about hypotension. So the question comes is that NPE, I don't need to introduce the group. The NPE is a neonatologist perform echocardiography group that was formed about 5 years ago, and Willem took a lead in that, and then Afif and Eric and me and Yogan, and the group has grown up, and now there are about 50 plus members on this. The whole job on the NPE is that how can we incorporate in the day-to-day clinical care. So the common indications, I don't need to inform the group, which most of them you are already convert, are the common indications that one would use the NPE on a day-to-day bedside clinical management. So what is NPE or the functional echo taught us? I think first is dispelling the myths. And this is work from Dr. Nick Evans, who was among the forerunners in using the functional echocardiography on the bedside. And one of the things what he suggested, that our view about the duct changed. So the traditional view, if you look at, it was before the bedside functional echo was done, was that ductal arteriosus in very preterm infants has minimal constriction, and the early shunts are balanced or right to left, and the shunting is not hemodynamically significant, and hemodynamic significance is marked by development of physical signs. But we now know that all of this is not the fact, and with the bedside serial echoes, we have learned that there are a wide range of constriction of duct. Early shunting is predominantly left to right unless a problem on the pressures. The large left to right shunts can occur very early after birth, and that the hemodynamic significance, it precedes the clinical signs by a median of about 2 days. So clearly our thinking has changed about what we see on the transitional circulation and how we can use this information. This is slightly old, but what I did was I compiled for the 5,000 babies as what was the different treatment strategies of treating the PDAs. So prophylactic approach, early asymptomatic approach, and a symptomatic comparing indomethacin and ibuprofen. At that time, the paracetamol use was not a lot, but what we find is that all of them, they suggest that you give a drug, it closes the duct. No surprise there. So all significant. But except this, when you compare the indomethacin and ibuprofen, the neck was low, significantly low, and the duration of ventilation had improvement. But apart from this, it did not translate into any evidence of any benefit or so. So we are stuck after enrolling 5,000 babies that what do we do about the duct? And the work started from, again, Patrick about 10 years ago, where they started looking into the clinical science and correlation on the echo, that what was the clinical correlation about the size of the duct and the significance. We know about the clinical signs, we know about the common echocardiography signs, but these are more for the symptomatic babies. And subsequently, there were various parameters suggested by a group of people as measuring the duct size, dimension, more than 1.5, or the flow pattern. But then Afif did a great work, and he combined few parameters together with an area under the curve which was quite significant, as you see. And this is probably the best way to diagnose an early a duct which is unlikely to close or who might turn into hemodynamic significant duct. So the echo has on the bedside probably helped in identifying which PDAs to treat, and it allows for the patient selection. From there, this has been used now, and now the trials are underway which are looking at how do we address this problem of the PDA, because we are now going to have the objective approach of managing duct, and Benedictus trial run by Willem de Boud. Triocapi trial from France is already completed. Data is still awaited, and I've been leading the Baby Oscar trial in the UK, which is still recruiting. So hopefully in the future, on the objectively diagnosed duct by the intervention of choice, we might understand whether the approach has any benefit or not. And we look forward to the results of all the trials. Now, we talked about the duct. What about the pulmonary hypertension? And I think this is a problem we face on a day-to-day life. And the management of the pulmonary hypertension by people who are either doing the bedside functional echocardiography or those who have access to functional echo done by the pediatric cardiologist certainly helps in managing these babies. And in a simplistic way, doing the echo, the important things are establishing the normality of the heart. And I think it is beyond the domain of the neonatologist performing echocardiography, but structural normality has to be established. Assess the function, pressures on the right side, and clinically correlate, and you can also assess the response to treatment. But the basic echo, as we see, it would have a variety of things. So you make sure that the heart is structurally normal and doesn't have a TAPVD. What is the septum? Is it flat or not? What about the duct? Is it right to left, as it is seen in here? But you see a pure right to left duct, suspect a cyanotic CHD. What about the TR and how much it is? And what are the other function of the right ventricle? So that was a basic echo that used to be done. But with the efforts of the NPE, this is a consensus paper which was published as a part of the series in the pediatric research last year, and it has been very well cited, and I think it has provided an objectivity and a guidance to how do we assess the duct using functional echocardiography. I'm sure you have read this, but just to recap, the four areas to assess are the pulmonary artery pressure, the pulmonary vascular resistance, the right ventricle performance, and the shunts. If you look in the four areas, you can objectively titrate the drugs that you want to use and give the treatment. There are various parameters which are listed here for pulmonary artery pressures, same way with the PVR, RV performance, and the shunts, and I don't think the time is there to go into details, but the full detail is available in the paper. Now, when we talk about the objective assessment of the pulmonary hypertension, we have looked at the four domains. A baby comes in who has you diagnose pulmonary hypertension, you start the nitric oxide, a baby responds. I don't think there is any magic in there, and many people might not even do echo in those cases. But it is a kind of a practice which is getting in that we start performing early. However, if you do not get a response to the treatment and there is no improvement in oxygenation, I think at that point, it is more or less now accepted that echo has a role in there. And with a bedside echo, if you do it, you can clearly classify, and this is from Satyan from US, that if there's a hemodynamic instability or rapid deterioration on the echo, you straightway get the ECMO on, activated, call the concern if you are having in-house or your center to be informed. If you have a hypotension and otherwise fine, the cardiac function okay, you might just want to start epinephrine. But if you have a hypoxemia, and depending on what it is, if it's a dysfunction of the LV or RV, you might want to give milrinone. If not, you might want to consider sildenafil. And you can follow on, and then if the therapies fail, you still have the ECMO. So clearly the functional echo on the bedside gives you a direction about selection of the drugs and how do we move forward about using the right drug for the right baby. Another aspect which many times we do the mistake of managing these babies is we not realizing about the pulmonary capillary wedge pressure and exposing the babies to the nitric oxide where the pulmonary capillary wedge pressure is elevated. So you see in certain cases where the pulmonary capillary wedge pressure is high, and you can see on the echo with a dilated LV and increased LA and diastolic pressure, these are the babies classically you should be very careful to start the nitric because they would deteriorate and not respond to nitric. On the contrary, if you have a right side problem and LV is not dilated and with a reduced preload, these are the ones which are more likely to respond to nitric. So even before going, I think this is a very easy way to look at the bedside to see whether it is of any use to select your drugs. Talking about the pulmonary hypertension, I think the next step we get on to is our day-to-day cases of the extreme preterm babies. The guideline or the Cochrane review, which is very old, it still suggests the choice of drug for managing these babies is dopamine, which again in the people with an interest, I think dopamine is probably going away. If you look at the baby who is into the low intrauterine vascular resistance with an immature myocardium is born and there is a high extrauterine vascular resistance. In addition, there is a shunt which is blood which is out in the systemic circulation and the positive pressure if the baby is ventilated. All of this, it leads to decrease in the systemic flow. Now, if you are not doing an echo and if you are depending on the blood pressure, you might even expose the immature myocardium to a high pressure situation, making the situation worse. And these are the situations where assessment of the cardiac output is very useful, because if you find that the cardiac output is low, then you might want to address the drugs which improves the cardiac contractility and reduce the SVR, like dobutamine, like milrinone. So they are the drugs which might be of your choice. But if you see that the cardiac output is normal and your blood pressure is low, your choice of drug might alter accordingly. This is a study by Hunt, and I just want to bring up this here because the blood pressure or the flow, which is more important. And they looked at about 126 babies who were under 30 weeks gestation. Of them, about 103 survived to discharge, and they followed these babies at 3 years of age for developmental assessment. And what they found was that they measured the blood pressure in the first 12 hours and 24 hours, and they looked at whether the correlation exists between the blood pressure and the outcomes at 3 years. So the death and any disability, there was no effect. Death, there was no effect. Abnormal DQ, no effect. I mean, there was basically this blood pressure was not found to be of any significant value in predicting any developmental outcome. However, when the SVC flows were looked at, it was noted that if the SVC flow is low and the longer the SVC flow continues to be low, there is a higher risk of a long-term neurodisability. So clearly, it is more flow dependent rather than pressure dependent. And I think this is very important finding, that we need to move away from the pressures to possibly the flows and to select appropriately the drugs that we want to intervene. Even more important about the brain perfusion. So if you look at the various levels of the cerebral blood flow are on the y-axis and the mean blood pressure on the x-axis. If you look at the ischemic cerebral blood flow, which is related to the mean blood pressure, and the functional CBF threshold, it is so narrow that it is very hard to differentiate when the baby switches from the functional cerebral blood flow threshold to the ischemic flow. And I think why I say that it is very important is the drive is to pick up the babies before they go into an irreversible states of shock, and we pick them in the compensated states of shock before they go into the ischemic area. And hence, with the blood pressure, it is very difficult. However, if you start looking at the cardiac output, it might be more reasonable and allow you to pick up the babies early. This is the Fennerov's criteria about the blood pressures at various hours of age, and that's the mean blood pressure and the centiles there. Now, we always talk about the oxygen delivery, and we know you all are aware of the DO2 depending on the cardiac output and the arterial oxygen content. Cardiac output, we know, is dependent upon the heart rate and stroke volume, and which is dependent on preload, afterload, and contractility. Now, that is a simple physiologic phenomena. But that's the work from Patrick again, which was published about 2-3 years ago, which looks at the reduced preload, reduced contractility, and the increased afterload. If you look at it here, the low pulmonary blood flow and the impaired filling can give rise to reduced preload. your cardiac contractility or the arrhythmia can give rise to the reduced contractility. And here it's a increased afterload. So doing an echo, it allows you to find out that the low cardiac output is because of any myocardial problem or it is because of the primary problem of the preload. And I think it is important because it allows you to stop injudiciously using the fluid boluses and preventing the baby slipping into the irreversible states of shock again. This is a composite diagram, a table which we published a few years ago as how do we assess the babies. And if you see, the hemodynamic assessment of the babies can be divided into 5 areas. So starting the preload, the pump, afterload, capillary, and end organ perfusion. These are the various clinical parameters. These are the non-invasive and they are the invasive. No doubt, when we talk about the arterial blood pressure, the intra-arterial blood pressure is the gold standard, but we commonly use the non-invasive as we are managing more and more babies non-invasively with less lines. But when it comes to the heart, which is the pump or the preload, I think the best way forward is to look at the echo, and that is where the NPE comes in. Is a whole article on assessment of the perfusion using the NPE. Not only that, you are all aware of the Safe Boost trial. The Safe Boost 2 trial, it did show that if you're following a protocol which is looking at the perfusion and the end organ perfusion, it allows you in reducing the hypoxic load. And when you talk about it, in the protocol, it's a very clear pathway where the echocardiography comes when the cardiovascular status is in doubt. So clinical assessment can be a bit delayed in terms of the findings because usually these findings are present when there's an irreversible shock. But the echo can pick up with the low output states or a duct and you can target the treatment accordingly. The Safe Boost 3 trial is already started recruiting with a larger sample size, and we hope that that trial might give an answer in the next 2 to 3 years about the usefulness of following an objective approach using the NIRS and the interventions which are more appropriate for the end organ perfusion. That's a slightly busy slide, but let me walk you through. This is about the BPD. This is a consensus statement that was published jointly by the European and the American bodies. And what it looks at, if you have a baby with a BPD, and if baby has a pulmonary hypertension suspected with that, you do a screening echocardiogram. That's the starting point. And then you also do NT-proBNP because you are wanting to look if there is a left-sided any volume of load there. You review this child and then see whether it is better, worse, or borderline. If the baby is worse, you again do an echo and consider treatment at that point of time in the pathway and start using the drug like sildenafil. Baby responds, well and good. If not, you might want to escalate and go on to bosentan addition. And this is something which they have suggested as a pathway for pulmonary hypertension coexisting with the BPD. Talking about the hypoxic injury or hypoxic encephalopathy, and this is the diagram again to show you the insult, the hypothermia, and the rewarming. So not a simplistic approach because the hemodynamics is very different when we talk about the different acute insult or a hypothermia or a rewarming. Why? Because hypothermia, there is a peripheral vasoconstriction and there is a bradycardia because of the treatment induced. Rewarming, there is a peripheral vasodilatation and there is a slight degree of the heart rate returning to normal. So depending what time frame you are, that the insult when it happens, apart from the adrenal injury, it could be myocardial ischemia, it could be pulmonary hypertension, they all can give rise to decreased cardiac output. During the hypothermic phase, it can potentiate or escalate the pulmonary hypertension, decrease the heart rate, and that can lead to decreased cardiac output as well. During hypothermia, there could be also an inadvertent, with the rewarming states, a rapid increase in cerebral blood flow, which may cause reperfusion injury. So you see the complexity of the diagram is there, but if you do not address and target the treatment accordingly, there might be a concern that we might be causing more harm than good if we are not using a bedside functional echo to identify at what stage we are. Pulmonary hypertension, unfortunately, it has not been reported in the hypothermia studies. And when you look at all the studies which have been done, the pulmonary hypertension was reported in about 40 to 60% of the cases, but that was not very well described in the papers. Same way, there were very arbitrary margins of defining hypotension. So the studies which have been done so far on the intervention using therapeutic hypothermia have not reflected well on the hemodynamic assessment. And I think there is a growing interest in this area to look into the babies which are undergoing therapeutic hypothermia and look at that what is the hemodynamic instability and can the intervention improve the outcomes with the concurrent intervention of a therapeutic hypothermia. So that's the way forward for the next few years for the trials to take out on. Not only that, with the hypoxia ischemia, there can be reduced perfusion and a decreased myocardial contractility and poor RV function. That can be potentiated further by increased pulmonary vascular resistance, causing decreased flow and decreased LV filling. So that can decrease the systemic and cellular blood flow. Why I have shown you this slide is because if you diagnose pulmonary hypertension with hypothermia, depending on whether it is isolated or if it is with a left ventricular dysfunction or with a right ventricular dysfunction, you might choose the drugs more appropriately. And this is just a table to summarize that whether you have pure dysfunction or with pulmonary hypertension or PPHN with RV or LV dysfunction. And that is a kind of not written in stone, not evidence-based, but physiologic-based approach to the drug choice in these particular states. Many of us come across these odd situations when there is a baby who was born after a prolonged PPROM and is a IUGR baby who is not very bad at birth, but in next 2 to 3 days deteriorates and goes down, and some of them they come out, but some of them they die with a very high degree of mortality. So this is the data which has come, which is from Boston, and this is just about 7 babies who are extremely low birth weight, with a IUGR between these gestations, birth weight of 450 to 790 grams, chronic fetal hypoxia and oligohydramnios. So these babies, majority of them were intubated, as you see, 6 out of 7, and within 6 hours they got it, and at 48 hours, 4 were extubated and 3 had low ventilator settings. Oxygen requirements were low. So essentially we start feeling these babies are getting better. But if you look in there, their right ventricular ejection fraction was a bit low. And not only with that, if you see with this pulmonary hypertension in place, these babies, majority of them, their ducts closed. So what was actually happening is, and it's a thought behind that why these babies succumb, is by the time they reach about 48 to 96 hours, their RV function is still not appropriate. If it is not appropriate and the duct closes, then the right ventricle is not able to maintain the perfusion, and these are the babies who go into refractory pulmonary hypertension, and unless the duct open or if we are on time with an echo done on time, these babies, we lose them. So there is a thought about that we need to be sequentially monitoring these babies with the bedside functional echo and hope that these complexities and the complications could be averted. We looked at from the European registry with the help of Dr. Nim Subedar that the babies with the arteriovenous malformation, what happens to the pulmonary hypertension and how they respond. So it was a retrospective study design of about 4 years, European INO registry from about 43 units in 13 countries. There were 9 cases identified and we took 36 controls from 1830 infants. What we found was that the INO, it does not have significant effect on oxygenation in neonates with pulmonary hypertension, which is secondary to AVM. We also found that AVMs have associated RV dysfunction and mortality, which is significantly higher than for other causes of pulmonary hypertension. So what it looked like, the choice of drug in cases with the AVM presenting with pulmonary hypertension, the RV function probably needs more attention than the pulmonary pressures with the use of the nitric oxide, because that is the point of the problem, and having a bedside echo again helps in managing these babies. So I've tried to give you a few scenarios in our day-to-day practice where the bedside functional echo could be of use in titrating the management, identifying the problem early, and following them the response of the treatment. Now, in the next 5 minutes, I'm going to take you through a few cases, which are the real cases, and as you will see in some of the slides, that there is a date, so they are quite recent. So this is a 23 plus 1 week gestation baby who had echo done at 24 hours of age with a moderate PDA, which was 2.4 millimeters, received 3 doses of ibuprofen to treat the duct. Baby was started on inotropes to support the blood pressure and the perfusion, Echo done at 24 hours of treatment, there was a small PDA. So you can see clearly here that this is the flow, which is quite reasonable. You look at the duct, which was about 2.3 millimeter here, and that was the left ventricle, which was volume loaded very soon, and this baby received ibuprofen. So that was the picture. The output on the right side was good, and the septum is bulging into more onto the right side. So this baby by day 5 died, and this baby, when it was looked at, had a refractory pulmonary hypertension. The mom's placental report came as chorioamnionitis, and the sepsis was clearly out there, and underlying cause extreme prematurity. You look in here, and that was just before dying, that was the echo for this baby. Unfortunately, over the weekend, the echo could not be done, and probably this baby slipped into pulmonary hypertension, quite bad, which was not expected. We rarely see a situation like this. And here is the baby, which is a very grossly dilated right ventricle, completely pinching the left ventricle, and hence you see the TAPC, which is there, which is very, very low, so right ventricle was poorly functioning, and if you see, is a global dilatation, and hence the baby was lost because of the pulmonary hypertension due to possibly chorioamnionitis or the drug effect. We can't say that. Another baby, it is a BPD with no evidence of pulmonary hypertension that was there. 90 days old, so not every BPD who is 3 months old has a pulmonary hypertension. That's what I want to address it here. Birth gestation was 26 weeks. Then birth weight was 510 grams, was 1350, was extubated, as you see, it was recently on CPAP, and the DART protocol was baby receiving second course. Good RV function, as you can see, TAPC of about 8 millimeters. You see the RVOT diameter is on here, but the QPQS was 1.0, so systemic and pulmonary blood flow was equal. You look in here, there were no shunts between the atria. There was a normal RV CI and the LV CI, so more or less good circulation. And if you see in here, this is the contractility, so the LV is nicely contractile, so no evidence of pulmonary hypertension. On the contrary, this baby on is a different baby on 43 days old, is 27 weeks and 2 days. On this baby on high frequency ventilation and a MAP of 18 and amplitude of 28, frequency of 11, 100% oxygen on INO 20 and milrinone. We decided not to go for escalation of care. If you see, there's a TR out here, and you can see there is a very steep rise of the flow here, and we call the PA80, which is very low, and the PA80 to the ET ratio was again less than 0.2 here. This is you see the septum, which is more or less flat. You look at the finding on the duct, which is right to left. You find the TAPC, which was about 4 millimeters. Again, the RV function is not very good, and hence, looking at these findings, it was decided with the poor RV function, high pressures, and the condition of the baby to withdraw the care on the baby. So echo can be useful in looking at if the non-response to treatment, what is appropriate for the baby, and is there a way to go forward. I can't advance. Okay, so this is another baby who is born at 27-week gestation, 800 grams, one of the twins with twin-to-twin transfusion, got a resection of 8 centimeter of necrotic bowel because of NEC. Subsequently, the echo was done. This is about a year and about 2 months ago. For the time's sake, if you see the LV wall is quite echogenic, if you can see here, and in another view, you can see the papillary muscles are also quite echogenic. This is the parasternal long axis view, quite echogenic septum and the left ventricular posterior wall, and here is a color Doppler picture, which is hardly any TR of any significance, but a very bright wall. So the problem was it is endocardial fibroelastosis in a small baby who has underwent the surgery for neck, or it is a state of endocarditis. The baby was started on treatment, and subsequently it was noted that this baby is been followed up, and the brightness of the wall, it decreased, and then by 3 months of age it disappeared, and it looked like a reversible condition. This is another baby who was admitted at 9 days, born at term by a spontaneous delivery with tachypnea, and the cardiomegaly was there on the X-ray. The echo was done, and it showed a poor LV systolic function, and it is evident here, as you can see. This is a flow across the interatrial septum. It's mainly left to right, but if you see the ventricle, it is very poorly contractile. So this is the LV, which you can see is hardly contractile, and the ejection fraction was about 50% only, and again, it's a dilated LV with a poorly contractile heart. This is the EA ratio, and this baby was subsequently found to have the myocarditis, treated with the captopril, and the systemic vascular resistance was dropped in, and baby improved over a period of time and got better. Another baby is born at 37 weeks, about 4.5 kgs, initially diagnosed as MAS and PPHN, was transferred on iron and FHFO. The echo was not done on the bedside there. As the baby comes in, it's an infant of diabetic mother. You find a thick in septum and a thick posterior wall, and apparently there is a duct which was mainly left to right, and you find that the EA ratio is again is reversed. You find out here that there was a very thick septum again here, and these are the ways that it helps you in managing these babies, because what we did was we started decreasing and tried to improve the cardiac output, decrease resistance, and the baby got better because pulmonary hypertension was not that severe. It's a baby with a pericardial effusion. Am I going 30 seconds?
30 seconds.
Okay, thank you. So this is a baby which is a pericardial effusion. I'll be very quick there. As you see, there's a large collection in there, and the contractility was still compromised. If you see the right atrium, it is collapsing, and then this effect of the fluid. But it's a very interesting case because you see the left ventricle wall, the fluid after we required 3 to 4 times tap, but it was quite bright. And when it was looked in here, there was no other findings. So what happened was, subsequent to that, the baby then tapped, and you look at the septum, which is still, the posterior LV posterior wall is still looking very bright, and essentially this child came out to be kind of a hemangioma of the left ventricular wall. Propranolol was started, baby got better, and then was discharged home. So I want to take you through a few more cases, but the time doesn't allow me. What I want to stress here is, apart from our day-to-day cases that we come across, doing a bedside functional echocardiography helps you in picking out certain anomalies which you don't think of, but they help in managing these babies more appropriate.